So how the capillary fluid exchange. How we have the fluid exchange in the capillary between the inside this capillary and the outside, which is the interstitial fluid. How the fluid in the capillary and the fluid in the interstitium exchange. What determine the direction of the fluid? Now, Starling forces determine the fluid movement through capillary membranes. So you have this equation here. First thing, you have BC, the pressure in the capillary. The capillary pressure push the fluid out of the capillary. If you have more pressure in the capillary, and so this pressure inside the capillary will push this fluid from the capillary to the outside, to the interstitial fluid. Okay? So, on the other hand, if you have pressure interstitium is high, if the pressure in the interstitial fluid outside the capillary here, the pressure in the interstitium is high, this will push the fluid from the interstitium to the capillary. So interstitial fluid pressure push the fluid into the capillary. Now if you have here, if you have the plasma colloid osmotic pressure, which means the proteins, the albumin inside the capillary, the subunits, and all of that stuff. So the plasma colloid osmotic pressure is high. So this plasma colloid osmotic pressure increase the concentration inside the capillary. The high plasma colloid osmotic pressure, you have more concentration inside the capillary, so the fluid will come into the capillary. So increasing the plasma colloid osmotic pressure will pull the fluid into the capillaries. Now, what about the interstitial fluid colloid osmotic pressure? If you have more proteins, more subunits, increasing the concentration in the interstitial fluid outside the capillary, so you have high concentration outside, so the fluid will go from the low concentration, which is inside the capillary, to the high concentration in the interstitium. So if you have interstitial fluid colloid osmotic pressure high, this will pull the fluid out of the capillary. Now here you have equation, which is GV. What is GV? It's the net fluid flow. The net fluid flow equal the permeability of the capillary to fluid, the permeability of the capillary multiplied by the difference between the pressure in the capillary minus the pressure in the interstitium. Okay? Minus the permeability of the capillary to protein, which is this here, this symbol, multiplied by the difference between the osmotic colloid pressure. The osmotic colloid pressure, which is the proteins and concentration inside the capillary minus the osmotic pressure and the proteins inside the interstitium. Okay? Here you have edema. When we have edema, we know that it is excessive fluid outflow into the interstitium. We have more fluid that goes from the capillary to the interstitium or to the tissues, okay, between the tissues, between the cells. So interstitial fluid increase. What the causes for edema? Of course, if we have increase in the capillary pressure, the pressure inside the capillary is very high, and this will push the fluid from the capillary to outside, so you will have edema. And this you see it in cases if you have heart failure, because we know that the heart failure, we have a lot of volume inside the blood vessels. You have more volume in the case of heart failure, so you have more pressure in the capillaries. If you have more pressures in your blood vessels, this will push the fluid from the capillary to the outside, and that's why if you have one of the symptoms or signs of heart failure is to search for edema in the ankles and in the lower limb. Now, in case also there is another thing that affects edema or to cause edema is if you have decrease in the plasma proteins. Decrease in the plasma protein, like if you have hypoalbuminemia, the albumin, if this albumin is decreased, which is a protein that it is produced by the liver. The liver produces this albumin, which is the most important protein in the blood vessel. So if this albumin concentration or the protein concentration is decreased, you have albumin decrease, so the concentration in the capillary decrease, so you have the fluid will go from low concentration, which is in the capillary, because you have hypoalbuminemia. The fluid will move from the low concentration to the high concentration. Thus, you will have edema, more fluid in the interstitium space. Okay, now, if you have increase, and this decrease in the plasma protein, if you have liver failure, because this liver, which produces the albumin, so if you have liver failure, you have hypoalbuminemia, less proteins in the blood vessel. Okay, and also this liver to produce the immunoglobulins and all proteins, yes? A lot of proteins is produced by the liver. If you have liver failure, low proteins in the plasma. If you have low protein in the plasma, more fluid will go out of this blood vessel. So you will have edema. Another cause for decrease in the proteins is nephrotic syndrome. We know that in nephrotic syndrome, the kidney excrete a lot of proteins. Yes? So one of the ways to diagnose it, to make a urine dipstick, for example, to search for the proteins in the urine. If you have more proteins in the urine, the kidney excrete a lot of proteins. So in the plasma, in the blood vessels, you have decrease in the amount of proteins. Decrease in the concentration of proteins in the blood vessel will lead to edema, because the fluid will move from the low concentration blood vessel to the interstitium, where there's a more proteins and more concentration. And this will cause edema. Now you have, if there is increase in the capillary permeability, the capillary permeability increase. This will pull this fluid and also proteins outside of the capillary. Okay? So this will lead, like case of toxins, if you have toxins, infections, and burns. We know that these cases, these diseases, will increase the capillary permeability. So you have the protein out, the proteins going out of the capillary to the interstitial fluid, and also this, what will do, the water, the fluid in the blood vessel, it will go out of the capillary, so you'll have edema. Now, in case of you have increase in the interstitial fluid colloid osmotic pressure. Colloid osmotic pressure is the same as you have more concentration, more protein outside of the capillary. You have more concentration outside the capillary in the interstitial fluid. So the fluid, the water in the plasma, will move from the capillary to outside the capillary, and that's, you will have edema. And this increase in the fluid colloid osmotic pressure in case you have lymphatic blockage. You know that lymph take the nutrients and make drainage of them, yes, and then return this fluid from the lymph to the veins. So if you have lymphatic blockage, more nutrients, more proteins, and other stuff will stay in the interstitium fluid. So there you have more concentration of interstitium fluid. So the fluid will go from the capillary, low concentration, low osmotic colloid pressure, to the high osmotic colloid pressure, which is in the interstitium, and this is how you will have edema. Okay? I hope that you understand. This was the last topic in the physiology, and now we will continue talking about the cardiovascular pathology. So today is the first lecture in cardiovascular pathology in the USMLE Step 1 book. Okay? So the first topic we want to talk about it in the cardiovascular pathology, which is the disease, how the disease occurs. This is pathology, yeah? So now we have the congenital heart diseases. Congenital heart diseases, as we know that congenital means prenatal, before you get birth. So these symptoms of that disease, which is found before you birth or before the baby gets birth, he have a disease. So the symptoms of this disease will immediately be shown at his birth, immediately, or in his childhood. So the disease symptoms will be early in his life because it's a congenital disease. Now we are talking about the congenital heart disease and specifically. So heart disease that occurs prenatally or at birth, we call it congenital heart disease. Now, one of these is like if you have right to left shunt. So the diseases of the heart, the congenital disease of the heart, are divided into two categories. The first one, if you have the blood shunt from right side of the heart, which is right atrium, right ventricle, to the left side of the heart, which is the left atrium and the left ventricle. This is the first category, which is from the right to the left side. And all of you know that the right side of the heart carry the deoxygenated blood, the blood with less oxygen concentration. So if you have blood with less oxygen concentration that goes to the left side of the heart, and then this left side of the heart will pump this deoxygenated blood to the body, you will have cyanosis. Cyanosis is the blue coloring of the skin. Cyanosis, because most of the blood is deoxygenated, and we know that the color of the deoxygenated blood is slightly blue. Yes, it is darker than the oxygenated blood. That's why if you have more deoxygenated blood in the body, you will have cyanosis, which is blue coloring of the skin. Okay? And the other category, we'll talk about it in the next lectures. Now, the first one is if you have a shunt from the right side of the heart to the left side of the heart. We call it the right to left shunts, which of course is part of the congenital heart diseases. Now, early cyanosis, as we say, you will have cyanosis, which is blue coloring of the skin. You will have cyanosis because you, as we say, deoxygenated blood will go from the right side to the left side, and this left side, left ventricle, will push this blood through the aorta. Yes, through the aorta, it will push all of that deoxygenated blood to your skin, to your brain, and so on. It will cause a lot of diseases. So you'll have early cyanosis at birth when this baby gets birth. Okay, so he will have cyanosis, blue skin. The first thing you need to check his respiratory system, his heart, to check that if he has congenital heart diseases or he don't. Okay, so early cyanosis, blue babies, as we say, you will have a blue babies, blue skin colored babies. Also, you will look for the mouth, for the mucosa, for the fingers, okay, and so on. Toes, yes. So often diagnosed prenatally or because evident immediately after birth, okay? Or become evident immediately after birth. Just as we say, you will diagnose this heart disease, congenital heart disease, prenatally, before his birth, before the baby gets born, okay? Before the born of the baby, you can diagnose him by the ultrasound and so on, okay? So if you do ultrasound before the birth of the baby, before the delivery of the baby, you can diagnose him if he have any congenital heart diseases, okay? So yes, now prenatally before birth, or you can diagnose him immediately after birth. Why? Because there is symptoms. There is a blue color skin. He is cry a lot. He don't eat. He's only in fatigue, lethargic. Okay, he not active all the time. He can't feed well. All of that. He don't gain weight. All of that are symptoms that he has non-efficient heart, a diseased heart. Okay? So, usually require urgent surgical treatment. He has a problem in his heart, and this is required an urgent surgery to treat this disease, okay? To repair the heart. So you need urgent surgery because you need him to speak, to grow, for example, okay? So you need to do emergent surgery, treatment, and sometimes you need to maintain the patent ductus arteriosus. You need to maintain the patent ductus arteriosus. We speak about it in the previous lectures in the physiology or in the embryology part. We talk about the patent ductus arteriosus. We say that the patent ductus arteriosus is, from its name, ductus arteriosus. Patent means open. Ductus, it's a duct between arteriosus, between two arteries. So patent ductus arteriosus. So you have open duct between the two arteries. What is the arteries? The first one is the pulmonary artery, and the aorta. Okay? So the first one is the pulmonary artery and the aorta. So sometimes to maintain a good blood or good oxygenation to the baby, you need to maintain these ducts. So you have a mix between the oxygenated and deoxygenated blood. Okay? We will see later how this happens. Now, some examples of, or roughly, there are 5 diseases. There are 5 congenital heart diseases that cause right to left shunt. From the right side to the left side, there is shunt of blood. The blood goes from the right side of the heart, right atrium, right ventricle, to the left atrium, left ventricle, right shunt. So there's 5 diseases that cause this right to left shunt of blood. The first one, all of them is 5T, okay? To remember them, they are the 5T, okay? All of them begin with T letter. So truncus arteriosus, the first one. The second one, transposition of the great vessels. You have tricuspid atresia. You have the teratology of Fallot. And you have the truncus anomalous pulmonary valve, which is here. Okay? Total anomalous pulmonary venous return. Total anomalous pulmonary venous return, we will talk about it, okay? Which is drained to the right heart. The pulmonary veins, you know the pulmonary veins that get the blood, the oxygenated blood. The pulmonary veins, we say that, previously we say, the veins, it is the blood vessels that go to the heart. Each blood vessel that goes to the heart, it's a vein. Each blood vessel that go out of the heart, like the aorta, it's go out of the heart, okay? It is artery. The blood vessel that bring the blood to the heart, it is a vein. So you can imagine that the pulmonary system or the respiratory system, the lungs, bring a blood to the heart. And because this blood is coming to the heart, this blood vessel bring the blood to the heart, we call it vein. Okay? So, but you can also imagine that the pulmonary system will bring oxygenated or deoxygenated blood to the heart. Of course it will be oxygenated blood. So the pulmonary vein will carry oxygenated blood to the left atrium, from the left atrium to the left ventricle, from the left ventricle to the aorta, and so on, and from the aorta to the body. Okay? But if you have a congenital disease, congenital heart disease, like total anomalous pulmonary venous return, you will have pulmonary vein drain into the right heart circulation. Imagine that this oxygenated blood, oxygenated blood going to the right side. It is mixed with the deoxygenated blood, like what? You have here the superior vena cava. Okay, here the right atrium, the right ventricle, and this oxygenated blood come to the superior vena cava. And you know that the superior vena cava carries the deoxygenated blood, the blood with less oxygen. So imagine you have mixed the blood oxygen with the blood with high oxygen and the blood with low oxygen are mixed together. So the percent of saturation of oxygen in that blood will decrease, and this will create a disease. Okay, this will create a problem. So you have pulmonary veins drain into the right heart circulation, like the superior vena cava, the coronary sinus, etc., associated with atrial septal defect and sometimes patent ductus arteriosus to allow the right to left shunt to continue the cardiac output. Now, this is very easy question, very easy topic. Listen here to understand the point. We say that if you have pulmonary vein, like if you have here the right atrium, okay, here the right ventricle, this right ventricle will bring this deoxygenated blood to the lung. Yes, and from the lung you will have the pulmonary vein, this to the left atrium, from the left atrium to the left ventricle, from the left ventricle to the aorta. Now, imagine that you have this blood, this pulmonary vein, which carry oxygenated blood, comes to the right atrium, which also have deoxygenated blood. So from where the aorta will get this oxygenated blood? The oxygenated blood come to the right side of the heart, and the aorta is found in the left side of the heart. So from where the aorta will get the oxygenated blood, so it will push it to the body or deliver it to the body. So how the aorta will get this oxygenated blood? You need a defect. Okay, you need a defect like you need to have a defect like the ventricular septal defect. Like there is a defect between the ventricles, the right ventricle and the left ventricle. If you need a defect in order to this baby to survive, to still alive. Okay, so if you have a defect between the ventricles, this will push the blood, the oxygenated blood that come from the pulmonary vein. Okay, the oxygenated blood that come from the pulmonary vein, because this baby have a disease, and the pulmonary vein will bring this oxygenated blood not to the left atrium as it is normal, as it should be. It will not send this oxygenated blood to the left atrium. It will send it to the right atrium, and this is a disease. And so the right atrium have the oxygenated blood. Now what the baby will do? In order to survive, he need a defect in between the atria or between the ventricles in order to carry this oxygenated blood from the right atrium to the left atrium, and from the left atrium to the left ventricle, from the left ventricle to the aorta, or to have a defect in the ventricles. So the oxygenated blood that come from the pulmonary vein to the right atrium, from the right atrium to the right ventricle, from the right ventricle, it need a defect to go from the right ventricle to the left ventricle, so the left ventricle can push this oxygenated blood to the aorta and so to the tissues of the body. Okay, so in order to this baby who have the pulmonary veins come to the right side of the heart, in order to this baby to live, he need a defect either between the atria, like the atrial septal defect, or between the ventricles, like in case of ventricular septal defect. It's a must, okay, in order to this baby to live. So now, and it's also one of the things that we do to treat this patient or this baby, okay? So yes, let us continue. Now we were discussing this one. Yes, the total anomalous pulmonary vein return. or pulmonary venous return. Okay, this is one of the causes of cyanosis. Cyanotic heart diseases, congenital heart diseases that cause cyanosis because of the right to left shunt of the blood. Now, we say that they are 5T. Now, the first one is truncus arteriosus. Now, what is truncus arteriosus? A persistent truncus arteriosis is a truncus arteriosus fails to divide into pulmonary trunk and aorta. And if you remember, we talk about this in the embryology because all of that are congenital heart diseases, and we talk about them in the embryology part. Now here in pathology, the persistent truncus arteriosus, what is the cause of this problem? You know that normally we'll have the pulmonary artery going out of the right ventricle to the lung. This is pulmonary artery. Why it is artery? Because it's going out of the heart. It's going out of the heart to the lungs. So it is artery. It is the pulmonary artery. Yes? So the pulmonary artery will take this blood to the lungs. This is normally. And this pulmonary artery should go out of the right ventricle. And from the left ventricle, you have the aorta that takes the blood to all the body. Now, in case you have truncus arteriosus, and as you know, that the pulmonary artery carries the deoxygenated blood. The deoxygenated blood. Okay, less oxygen. While the left ventricle, the aorta, carries the oxygenated blood to the tissues. But if this baby have resistant truncus arteriosus, which means that this trunk don't divide. There's no septum between the aorta and the pulmonary. Okay, during embryology. They don't divide during the embryo time. When he was embryo, these blood vessels don't divide. So what you will have? Only one blood vessel. This one only blood vessel, it carries the oxygenated blood and deoxygenated blood. Imagine that you have here deoxygenated blood is mixed with the oxygenated blood, because here you have the aorta, here you have the pulmonary. There's no septum between them. Okay, this is what we call persistent truncus arteriosus. So the truncus arteriosus is the fails to divide into pulmonary trunk, which is pulmonary artery, and aorta due to the failure of aorticopulmonary septum formation. We talk about the aorticopulmonary septum in the embryology part. So the aorticopulmonary septum, it should divide the blood vessel or the aorticopulmonary to aorta and pulmonary artery. If they fail to divide, this will lead to persistent truncus arteriosus. Okay? The septum formation is defected. Okay? Failure of formation of the aorticopulmonary septum. The septum failed to develop. If the septum failed to develop, you have aorticopulmonary trunk. Okay? You don't have any septum between them. So this is one blood vessel that it is the aorta and the pulmonary. It is only one. You don't have a septum between them to separate them. Okay? And as we say, most patients have a combining ventricular septal defect. Also, most patients, they have, with this resistant truncus arteriosus, they will have ventricular septal defects. So, like this, you'll have here the heart, only one truncus, which is here you have the right ventricle, the left ventricle. And here you have here the pulmonary and aorta in the same blood vessel. Okay, and also most of them they will have ventricular septal defect, which is the defect between the septum, the interventricular septum, the septum between the ventricles. Most of them also they will have a defect here. Okay, so the blood also will move from the left ventricle to the right ventricle, from the right ventricle to the left ventricle. You have here a defect, and also they are mixed here. The blood from the oxygenated and deoxygenated blood are mixed in the truncus arteriosus if it is persistent truncus arteriosus. Okay, now, what is the transposition of a great vessel? It's the same concept actually. It's related to aorticopulmonary trunk if it is failed to spiral. What does this mean? And now the transposition of great vessels. You know that normally the aorta is coming out of the left ventricle. And normally the pulmonary artery is coming out of the right ventricle. Yes, here you have the pulmonary and here you have the aorta. Now what will happen in transposition of great vessels? In the transposition of great vessels, which is a disease and the congenital disease before birth, okay? This blood vessels, you will have the aorta coming off the right ventricle and the pulmonary is coming out of the left ventricle. Imagine that you are pushing to the body or pump to the body a deoxygenated blood from the aorta. Imagine that you have from the aorta, you are pushing a deoxygenated blood. Like this here, this photo here, this picture, to make the idea more clear, you have here transposition of the great vessels. So you have the aorta, okay? Here you have the aorta that comes from the right ventricle, and here you have the pulmonary artery comes from the left ventricle. Imagine that this aorta that carries blood to all the body, it carries a deoxygenated blood. Okay? So here, aorta leaves the right ventricle and the pulmonary artery leaves the left ventricle. Separation of systematic and pulmonary circulation. This will lead to separation of the systematic and pulmonary circulation because you know this pulmonary, the blood that goes to the lung, the lung will oxygenate the blood and will come back to the left atrium, and from the left atrium it will come back to the left ventricle. From the left ventricle, it will go back again to the lung. So from the lung to the left atrium, from the left atrium to the left ventricle, from the left ventricle through the pulmonary artery, it will go again to the lung. So it's a closed loop, okay? Like if there's separation between the aorta and the pulmonary. Imagine that there's a separation between the circle of the oxygenated blood and the circle of the deoxygenated blood, and only the oxygenated blood is already going to the lung only, from the lung to the heart, from the heart to the lung only. There is no oxygen that goes to the body. So this will lead to separation of the systematic and pulmonary circulations. Imagine that the superior vena cava, inferior vena cava will get this deoxygenated blood. The blood with less oxygen is coming to the heart, and from the deoxygenated blood that comes to the heart through the superior and inferior vena cavas, it will go to the right atrium, from the right atrium to the right ventricle, from the right ventricle through the aorta, it will carry the deoxygenated blood. And again, this deoxygenated blood, it will not go to the lung, okay? Because we don't have in the right ventricle pulmonary artery, so it will not go to the lung. It will continue. This deoxygenated blood, the same deoxygenated blood will go to the body again through the aorta. So there is a separation, a total separation between the systematic and the pulmonary circulation. Okay? So it is not compatible with life. No one can survive with this. His brain is taking a deoxygenated blood. His organs taking a deoxygenated blood, the liver, the kidney. Yes? So how he will survive? He need a defect in order to survive. He need to have a defect. Another defect that carries this oxygenated blood from the pulmonary artery to the aorta. It's need this defect to live, which is the patent ductus arteriosus or ventricular septal defect. And as we say, or patent foramen ovale. Now let us talk about these three defects, which is this one. The ventricular septal defect, the patent ductus arteriosus, patent foramen ovale. And we talk about all of this in the embryology part. Now, here, the ventricular, we say that they are in total separation. Yes, as it was shown in the picture, they are in totally separation between the systematic and the pulmonary circulation. Now, and we say that we need a defect like the patent ductus arteriosus, the ventricular septal defect, the foramen ovale should be patent in order for this patient to live. So you need a defect here, a defect in the septum. Okay, you need a defect in this septum. It needs to be a defect that carries this oxygenated blood from the left ventricle to the right ventricle, so he can survive. Okay, or you need a defect between the two atrias. This is here the atrium, and this is here the atrium. You need a defect between the atrial septum. Here the left atrium, the right atrium. You need a defect here between them, which is the foramen ovale. Yes, we know that foramen ovale is the opening between the atria, between the two atria, and it should close after birth. But in this patient, if this opening close after birth, he will die because there is separation between the oxygenated and deoxygenated blood. So this opening is crucial for him to live. Yes, there should be an opening in order to carry this oxygenated blood that come from the pulmonary artery to the left atrium, the oxygenated blood, yes, that comes from the pulmonary vein after the lung take the blood from the pulmonary artery. So it will need to get this oxygenated blood from the left atrium to the right atrium. In order to this patient to have oxygenated blood from the right atrium to the left to the right ventricle, from the right ventricle to the aorta, and so on. So he can live with a mixed blood, which means you have oxygen and deoxygenated blood. Okay? So the other defect is like this one here, the patent ductus arteriosus, and we say that the patent ductus arteriosus is an opening between the aorta and the pulmonary. You have an opening here, and this open, it will carry this oxygenated blood from the pulmonary to the aorta, yes, in order to him to live, from the oxygenated blood to the deoxygenated blood. Okay, so he need a patent ductus arteriosus to live. So he need a patent ductus arteriosus or ventricular septal defect or patent foramen ovale, so he can live with this defected heart. Transposition of a great visits. Now, due to the failure of aorticopulmonary septum to spiral, we talk about this one. Here you have aorticopulmonary in the embryo, okay? In the embryo you have this aorticopulmonary trunk, and then you have the septum. Yes, you have the septum. So it will not be persistent truncus arteriosus. You already have the septum between them. Now this septum, if this septum don't spiral, don't rotate, okay? Don't spiral, and it's still as it is. Here you have aorta, here you have the pulmonary, okay? Here you have the right ventricle, here you have the left ventricle. This trunk need to rotate in order to opposite the locations. In order to this aorta to come to the left ventricle and this pulmonary to come to the right ventricle, it needs to spiral, to rotate. If it is don't rotate, don't spiral, it will cause a disease, which is transposition of great vessels. Okay, so this defect is due to the failure of aorticopulmonary septum to spiral. And on X-ray, you can see this like an egg, okay? Egg on a string. So it's like an egg on a string on the chest X-ray. If you order an X-ray for a cyanosed baby, you have blue arms, blue limbs, blue lips, blue mucosa in his mouth, okay, and blue tongue and all of that. He has central mucosa or peripheral mucosa in his hand and so on. And you think that he may have congenital heart disease, but you don't know which one yet. You'll order a chest X-ray. When you order chest X-ray, if you see an egg shape on a string, you can think, oh, maybe this is transposition of great vessels. Okay? So it's like an egg on a string appearance on the chest X-ray. Without surgical intervention, most infants die. And you know the reason. There is no oxygenated blood that go to the body. Yes? So without a surgical repair, without a surgical intervention, this baby will die. Okay, so you need to do a surgery, emergent surgery. Within the first few months of life, he will die within his first month of life. Okay? And here we continue. What is the tricuspid atresia? We also talk about the tricuspid atresia in the embryology part. Okay, for the cardiovascular system. Now, tricuspid atresia is like if you don't have tricuspid valve, you know that the tricuspid valve, it's the valve between the right atrium and the right ventricle. Yes, but if this valve don't even exist, okay, it don't even exist. This is what we call tricuspid atresia. Okay, so in tricuspid atresia, you will have the heart like this. This is here the right atrium, and here the right ventricle. There is total separation between the right atrium and the right ventricle. And imagine that this right ventricle have this pulmonary artery, from where this pulmonary artery will get this blood, the deoxygenated blood, from where? If you don't have a valve between these two chambers, you need a valve, you need an opening between these two chambers in order to carry the deoxygenated blood to the pulmonary artery, in order that this pulmonary artery can oxygenate the blood, can go to the lung, and this lung give us oxygen, so the oxygenated blood can be transmitted to the body through the aorta and so on. So if you have tricuspid atresia, there's totally separation between these two, the right atrium and the right ventricle. So tricuspid atresia is the absence of the tricuspid valve and hypoplastic right ventricle. You will have this right ventricle, it's not developed, it's not mature, it's hypoplastic, okay? Because no blood come into this right ventricle, so it is not mature, it is hypoplastic, okay? So absence of tricuspid valve and hypoplastic right ventricle requires both ASD, atrial septal defect, and ventricular septal defect in order to this baby to survive. Okay, it's need both. If you face any question like this one, which congenital disease need two heart defects or need atrial septal defect and ventricular septal defect to live? Not only one, he need two. He need both of this, the atrial septal defect and ventricular septal defect, in order to live. What's the answer? Of course, it will be the tricuspid atresia. So you need an atrial septal defect you need a defect between these atria, okay, that carry the blood to the atria, and you need a defect in the atrial septal defect. Why you need the atrial septal defect? Although you already have here blood, yes, that come from the superior and inferior vena cava. You already have a blood that comes to the atria. So why you need this defect? The answer is this. You have here a deoxygenated blood, yes, that comes from the superior and inferior vena cava. And this deoxygenated blood need to be oxygenated. So the circulation will keep going, yes? So this deoxygenated blood need to be oxygenated. And this will not occur it will occur only by this defect, which is the atrial septal defect. So the deoxygenated blood will go from the right atrium to the left atrium. Okay, it will go from the right atrium to the left atrium. So this left atrium will get this blood, deoxygenated blood, the mixed blood. Yeah, let's have a mixed blood, oxygen and deoxygenated. This mixed blood will go to the left ventricle. Now, from the left ventricle, to have oxygenated blood and deoxygenated blood. It also needs a defect between these two ventricles in order to this deoxygenated blood to go to the pulmonary artery. So should be a defect between the ventricles to transfer this deoxygenated blood to the pulmonary artery through the right ventricle. So you need to have ventricular septal defect. Okay? So that's it about the tricuspid atresia. Let us talk about the teratology of Fallot. And this also, we talk about it in the neurology part. Now, teratology of Fallot is from its name, teratology. Tera means 4, okay? Teratology of Fallot is like you have 4 defects in the heart that cause this teratology of Fallot, that cause this congenital heart disease. You have 4 defects in the heart. Now, teratology of Fallot is caused by the anterior superior displacement of the infundibular septum. The infundibular septum is that the septum near the outflow of the ventricles, okay, like near the aorta and near the pulmonary valves. This is what we call it infundibular. The septum near the pulmonary and aortic valve, we call it infundibular, okay? So if there is caused by anterior superior displacement of the infundibular septum. Most common cause of early childhood cyanosis. What is the most common cause of childhood cyanosis? If we are talking about the heart disease, the most common cause is teratology of Fallot. Teratology, you have 4 defects. Let us talk about them. We say that the septum between the aortic, which is the septum of the outflow, which is near the aortic and pulmonary valves, is displaced. So you'll have pulmonary stenosis. Pulmonary infundibular stenosis. You'll have this pulmonary valve is narrow. Okay, instead of being like this, it will be narrow like this. Okay, the opening is narrow. So pulmonary infundibular stenosis, most important determinant of our prognosis. How we determine the prognosis? How much this baby will live? His life expectancy. It is depending on the degree of the pulmonary stenosis. If you have severe stenosis in the pulmonary valve, it's a worse prognosis. So the prognosis is determined by the pulmonary infundibular stenosis. Now this is the first thing that you have pulmonary stenosis. As you can see here in the picture, here is the pulmonary stenosis. Yeah, this is the pulmonary artery, pulmonary valve. You have this pulmonary valve stenosed, narrowed. And this is what determines the prognosis at just what we say. Now the next thing is the next defect is you have the right ventricular hypertrophy. And as you can see here, right ventricular hypertrophy, increasing the number or the thickness of the right ventricle, the number of muscles, okay, or the thickness of the right ventricle. This will lead to right ventricular hypertrophy. And of course, you can understand why, because if you have pulmonary stenosis, narrowed valve, so more blood is in this right ventricle, more volume in the right ventricle. So more volume in the right ventricle, more tensions in the wall, and this will lead to hypertrophy. Yeah, after a long time. So you will have right ventricular hypertrophy, you'll have pulmonary stenosis, and this right ventricular hypertrophy will cause a boot shape, like the boot. Okay, a boot shaped appearance, like a boot. Imagine this is the leg and this is the boot. Okay, so the boot shaped appearance on the chest X-ray, you can diagnose it by teratology fluid. If you see a boot shaped appearance on the chest X-ray, you can diagnose the teratology of fluid. So as you can see here, pulmonary and right ventricular hypertrophy, which boot shaped, that will cause the boot shaped appearance on the chest X-ray. Now you have overriding aorta. The overriding aorta is like this one here. What is the overriding aorta? Is the aorta that it is going over both the right ventricle and the left ventricle. It's not only above the left ventricle, it's also above the right ventricle. As you can see here, an overriding aorta, which means the artery that carries high oxygen blood to the body, which is the aorta, is out of place and arises above both ventricles. Not only the left ventricle, both the right and left ventricle. And instead of just the left ventricle, which is normal. So normally the aorta is only above the left ventricle. If this aorta is above the left and right ventricles, it is overriding aorta. So this is the third defect that you have in the teratology of fallot baby. Now the last thing is they have ventricular septal defect. They have a defect in the septum between the ventricles. So here you have the ventricles. This is the ventricle, you have a defect between these ventricles. Okay? Ventricular septal defect. Now, pulmonary stenosis force the right to left flow across the ventricular septal defect. You can understand that. So you have, let us talk about this one here. Now, last thing we will say on this topic is that if you have this stenosis in the pulmonary, so you have more blood volume, as we say, yes, more blood volume in the right ventricle. Now the right ventricle become more thick. Hypertrophy, right ventricular hypertrophy. Imagine you have more volume in the right ventricle. This more volume will push this blood, this deoxygenated blood, the blood with less oxygen. The right ventricle will push this deoxygenated blood to the left ventricle through the ventricular septal defect, the defect between the two ventricles. So here you have more blood in the right ventricle, and this increasing the volume in of blood in the right ventricle will push this blood to the left side of the heart, to the left ventricle. And imagine that you have this deoxygenated blood going to the aorta and then separate to all your body. Imagine that this deoxygenated blood is spreading all over your body, so you will have a cyanosis. You will have the tit spills, cyanotic, okay? And this tit spills is like cyanosis that comes if you have fever, exercise, crying, because all of that will increase the effort on the heart. So you have this will pump more deoxygenated blood to the left ventricle through the defect, which is the ventricular septal defect, okay? In the baby who have teratology of fallot. So if you see a baby who have tit spills, like the mother saying that, when he cry, when he exercise or do some exercises like he is walking, he is running, and when he have fever, increasing the temperature, I noticed that he have cyanosis, a blue limbs, a blue fingers, a blue mouth, okay, and blue toes. For example, if we have this cyanosis that comes when he do an effort like exercise, fever, anything, you can think he has teratology of fallot. And this is why, because he have more blood volume, and so this more blood volume in the right ventricle will push the blood, the deoxygenated blood, to the left ventricle, from the left ventricle to the aorta, and this deoxygenated blood spread to his fingers, his toes, his body. So he has cyanosis, blue colored skin. Okay, because you have deoxygenated blood is more, so you have deoxygenated, so you have blue colored skin. Okay, and this cyanosis, we call this tit spills. Tit spills is found in teratology of fallot. Now, this is actually our lesson for today. I hope that you enjoy and you understand the lecture today. See you in the next time.